Good morning. This is Goel from IRACON-TV. We have Dan of spondyloarthritis with us. Dr.Denis, he is a university professor at University College of Berlin, Germany. Dr.Kay, he is professor of radiology from University College, Berlin, Germany. Dr. Denis is executive member of a Grapper group as well as SAS group. So, how are you feeling at IRACON, Dr. Denis?
Yeah, warm. In all meanings of this word. So I still it's really a great venue, and today we're running an MRI workshop on diagnosis of excess spondyloarthritis. And I have a feeling that people are really interested in this matter. So we do hope that we might do something positive to improve the diagnosis, the correct diagnosis of spondyloarthritis in India.
What made you venture into artificial intelligence from human intelligence?
Yeah, and so I still believe that human intelligence is better, and we're working right now on developing an artificial intelligence-based tools to enhance the diagnostic approach. So I envision that in the future we might have tools to recognize bone marrow edema, erosions, so particular features of spondyloarthritis, but this would be only an aid to a radiologist or to a rheumatologist, pointing out there are some changes compatible with the disease, but you need to make the diagnosis on a basis of the totality of the data.
Okay, you both work in the same hospital. So how do you collaborate with each other when you find a difficult case?
So actually we have consultations on a regular basis. That means we have every week a consultation with the team of Dr. Denis, and we advise them on their cases. So we look at images together, so that is very important, that not only radiologists look at the images, also the rheumatologists look at the images, get their own impressions, and we discuss. And that is very much contributing to the knowledge of the team of the rheumatologists, so they gain skills looking at the images themselves when they leave the hospital or when they have another position with less experienced radiology.
Wonderful. That is a good collaboration between you two.
Absolutely, and we learn from each other a lot.
And that is how you're teaching us here so nicely.
Absolutely. So we are educating fellows in this way, but I need to admit I'm learning nearly every week something new.
Wonderful.
And that's also why we take these, why we contribute these courses as a duo, because I think this very much helps understanding the participants that the two disciplines, rheumatology and radiology, they work together for the good of the patient, and therefore we also come as two persons for the workshops and doing them together.
So where do you take these courses? Is it online or offline? On which countries it is available?
So what we are using here today is the Berlin Case View platform. That is an in-house built platform from our university, and we created it from the beginning to conduct courses like this. So it's working on site, so we can have like computers like here, or we use iPads which we use for traveling. So that's for our on-site courses, but we also can do it online. So it is all working very good online, and we can use Zoom or Teams, and then we use our platform on top of that. And we did already courses in Brazil, in the Gulf region, in Germany, of course, all over Europe, and now in India. So we are not constricted to any region of the world.
Right. So you're going globally in teaching. That's very essential, actually.
We're trying to do that, because we see that even in Germany, we're working on this topic already for many years with workshops. We still see unmet needs. So you can imagine that in other regions around the world, with increasing use of imaging, the problem of correct interpretation for this imaging is growing. And we're putting a lot of efforts in education of rheumatologists, but also radiologists, and see from outside a growing interest within the radiology community in Moscow.
Okay. Dr. Kay, how do we differentiate mechanical bone marrow edema from the inflammatory one? radiological?
It's a big topic. So actually,
In a nutshell.
to give a lecture for another 60 minutes.
Okay.
But it is a challenge. It is a challenge, and the main issue why some people with mechanical problems are misdiagnosed with axial spondyloarthritis. We know nowadays that there is a specific pattern in terms of localization of bone marrow edema, in terms of accomplished structural changes, which might help to differentiate. For example, in a condition we call osteitis condensans EE, we see that bone marrow edema is confined to the very anterior portion of the sacroiliac joint, so mechanically affected area of the sacroiliac joint, and is normally not accompanied by changes, structural changes such as erosions. But in overall, it is a pattern which you can learn by looking at those cases at different occasions.
And does the shape of SI joint affect this?
Yes.
Like the bone marrow edema?
Yes, we learned in recent years that it is important to treat every sacroiliac joint as it were unique. So we know that there are 6 to 7 different types of shapes of sacroiliac joints, and these were published 20 years ago, but nobody did really take care of connecting it to the disease and to bone marrow edema. And now we know that men and women have somewhat different shapes of the sacroiliac joint, and also some types of the shapes are more prone for osteitis condensans and also osteoarthritis than others. And that's a new finding, and we are trying to incorporate these in our teaching courses.
Actually, there is no gender disparity in non-radiographic SPE. But when we come to radiographic one, there is male predominance. So why do you think there is male predominance? Why do males progress to radiographic as compared to females? Something to do with hormones or X chromosome?
Yes, so the alternative explanation for that has not been given so far, but it has something to do with the male sex for sure. And one of potential explanations why we see more structural damage, especially in the spine, is naturally high level of adipokines in females. So they have high level of leptin and high molecular weight adiponectin, and these biologically active substances, they might protect females from developing local inflammation or extensive inflammation. So they are protected in terms of structural damage and newborn development, at least in the spine.
Now, coming to artificial intelligence, it has already created a lot of ripple in the medical community. And the way it is progressing, it has already made several benchmarks. So, and you both have done a great work in artificial intelligence, especially in the imaging part. So, how do artificial intelligence helps a radiologist or in imaging a sacroiliac joint?
Yeah, I can start. So what I know, what is already reality in daily clinical practice is artificial intelligence enhanced reconstruction of images. So you can achieve, for example, great image quality with really low level of X-ray radiation exposure. This is very helpful. There are also techniques improving imaging quality of MRIs. Again, you can generate some new sequences which might help to recognize some particular changes. So you are also collaborating on this initiative. So in terms of structural damage,
or we can say what kind of lesions it picks up more specifically. So out of the inflammatory and structural lesions, what kind of lesions it is more specific or more useful?
Yes, I think Dr. Denis is mentioning especially techniques like bone MRI and susceptibility-weighted imaging that is contributing to the MRI imaging, but it produces images that look like CT images. And CT, as we know, has a very good option to image the bone. So CT is the gold standard to image the bone. So the lesion that we would look for are erosions, especially. And if an erosion is there, it has a very high specificity for a certain diagnosis compared to just ordinary edema. So we need to know if there's an erosion or not. And in the beginning, we worked with the white sequence, where we tried to use the high contrast of the cartilage compared to the bone. But this sequence was, you need some training in order to get acquainted to the depiction of this erosion. With the bone MRI and the SWI imaging techniques, you now have the same appearance as a CT scan. So the bone is white and all the other stuff is dark. So you see the erosion right away, and that's the advantage.
How can deep neural imaging and clusterings help in analyzing real-world data? Because real-world data is erratic and non-homogeneous. So how does it help in research and analyzing the data?
Yeah, I think it's still a bit open, because you always need very good standards of reference in order to train artificial neural network to recognize particular pattern or a particular patient profile. But what we see now, quite effective attempts to identify patients at high risk of spondyloarthritis based on electronic healthcare records or insurance data, for example. So there are specific patterns where we might recognize patients even earlier than now who are really suffering from axial spondyloarthritis, but where our physician didn't come to the idea that that might be something inflammatory.
Okay, coming to the last question, how does CNN that is being devised by you helps in identifying back pain patients? Like which patients are inflammatory, which are not inflammatory? Yes. How does this application or the software helps?
Yeah, this is still work in progress. So we applied convolutional neural network, which is more or less a current standard in the field of the deep learning, to identify pathological changes on X-rays, and that was quite effective, and it works very well. This is a tool which is publicly available, and everybody can try this. And where we're working right now is the same, but for MRI. This is a much more challenging game, where we have an issue of high quality standards, reference standard for the interpretation of imaging, and what is against us is huge heterogeneity of real-world images, protocols, and so on. So we're trying right now also to provide a sort of standardization to MRI imaging across the world, and at the same time we develop artificial neural networks for the recognition of typical active inflammatory and structural change.
Okay, please.
So right now we are in a phase to establish these methods in a set of images with where high prevalence of axial spondyloarthritis, and trying to identify the lesions and to characterize them, to maybe also estimate the amount of inflammation or structural damage. So the next step is to detect these changes in a more broadly data set, like as you said, a patient with general back pain is there, and we try to pick up if he's among the 5% who have inflammatory changes. And I think that's the next step, to have the general radiologist getting them help for their work. But on the other hand, these new technologies, they also need to be reimbursed. So I think it's a long way till we have this as a standard in every MRI machine, already checking for the rare things, because the people need to adapt it, and also need to think that it's worthwhile checking these before they do the report done by the human.
Okay, and the last, how can we take the research ahead in this area, especially in the country like us, where these kind of softwares and the expertise is not available? Can we do something like IRACON and the countries like us?
Yes, I think so. I think in order to develop, for example, high-quality algorithms to support the diagnostic approach. In the imaging field, we really rely on high number of images. So there is certainly a need for international collaboration in this field. We need a big study producing a big amount of data, which would be when it's sufficiently annotated and used for training of artificial neural network. I think this is certainly an area where we should collaborate.
I wholeheartedly thank you, both of you, for coming this far, for giving the interview, taking the time and teaching us. Thank you so much.